Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program and Southwest Telehealth Resource Center. Welcome to today's program. So today, of course, as you connected, some webinar tips and notes. Your microphones or phones were muted, but please use the chat feature for questions. You can go ahead and put them in as our presenters are presenting, and we will get to them. This is being recorded and it will be available on our website afterwards. I will be sending out a thank you email to everybody that has joined us today. And of course, I will have all of that information in there along with the URL for the evaluation. So everybody got this as they were registering, and some of the emails that have gone out, including on the flyer. I won't read through the whole information here, but this is the continuing medical education information. Our standard disclaimer. Don't need to read that either. And again, so please check our websites for upcoming webinars. We do have another one coming up in September, and it's going to be on, if I remember correctly, the Mighty Mites that Dr. Klotz is going to be talking about. I believe in Dr. York, right? And again, so your opinion is valuable to us. A URL will pop up behind the screen, the Zoom link, the Zoom screen that you're in, and that will be the evaluation for today's session. I will also have that URL link in my thank you email, so you can do it at your leisure at a later time. It's always best to get it done right away so you don't forget, though. And today I'm going to go ahead and pass our mic over. Oh, Dr. York, your picture is a little blurry. I'm gonna have to fix that. I don't know. Anyways, all right, Dr. York, I'm gonna go ahead and pass it over to you.
Back to the future.
Good.
Already.
Yeah, it's working about my.
They did the wrong.
All right, Dr. York, who do we have with us today?
All right, so we have got Dr. Ampel, who, if you were here with us, goodness, was this 2 months?
2 months ago. 2 months ago.
It feels like a long time. So he is joining us from all over this place. This man does everything. I could not possibly hope to cover all of the things that he has done. So I will leave his biggest things to him. But we are going to talk about today some mosquito-borne things. And I want to mention that more as an introduction. If you are new to us, we try to focus on envenomations, intoxications, and travel-related diseases. So we've been doing this now, I think about 2 years. It's gone by pretty quickly. And we've covered just about as much stuff as we can think of for you folks that are out there. So we've really tried to orient this towards folks in the emergency room, our EMTs, folks that are more likely to maybe see some of these things out in the field and give it more of that unusual slant. Maybe it's not something that we see all the time, or maybe just giving updates on some practices. But over about the last year or so, we've really been basing our topics more on your all's suggestions. And as a result, we've had some really interesting topics that we've talked about. Today is no exception. We're going to get into some mosquito-borne illnesses. Specifically, we're really going to get more into West Nile virus. So take a look at this list. We have covered quite a few things that are on here. We've talked about rabies. I think ORF was actually how we started off our second set of these sessions. But if there's anything that you don't see on here, please make sure in your evaluation you put it in there. We would love to keep doing this as long as you all would love us to keep doing it. So if there's anything you'd like covered, any updates, please let us know. And with that said, I'm going to turn it over to Dr. Ampel, who is going to tell you more than you ever thought you wanted to know about mosquitoes and West Nile virus. All right, it's all yours.
You're gonna do the slides for me?
I will get that set for you in just a second.
Okay.
Get my share section. One. All right.
I don't know how you keep it straight.
I got three big screens here that I'm managing, folks. I'm gonna move this one over here. So that way we're looking at the camera. And I'm gonna go ahead and
Can you make it bigger?
I can make it bigger. Yes.
Yeah.
Can I can get the camera in the right place here. Hold on just a second here. There we go.
If not, also.
All right.
Yes.
And then use the mouse and you can go
Just right.
use right on the arrow right there.
Okay. All right. So as Larry said, we're going to talk principally about West Nile virus, and we'll sort of morph into a couple of other things. But I think for those of us who practice in Arizona, this is an important entity. And it begins with a case that occurred back in August 2021 while I was at Mayo Clinic in Arizona. One of my patients who I followed for valley fever came to me because a 78-year-old man, he had developed fever, headache, concentration, and memory issues. And this occurred while he was vacationing in Ohio in late August 2021. And he went to an emergency room there and a lumbar puncture was performed. And the CSF analysis revealed about 110 white cells, which were principally lymphocytes, a glucose of 75, a protein of 110. But as best I could tell, no other tests were performed, and he improved. He's a generally healthy man. He had hyperlipidemia. He also had pulmonary coccidioidomycosis. So when I saw him, he felt improved, but he still had concentrations and balance issues. So looking at this, I said, well, this pattern is what we often call a viral meningitis. That is a fairly low white count that's mostly lymphocytes, normal glucose, normal protein. And actually at that point, I decided I better see where this sort of sounded like West Nile to me. And so I Googled it. And shockingly, I found out that the epicenter for West Nile in 2021 was Maricopa County. So he had almost certainly acquired infection before he left for Ohio. And we'll go over what happened in 2021 in Arizona to make that go up. So he was given a diagnosis of West Nile neuroinvasive disease and referred to neurology for further care. So what is West Nile virus? Well, it's a neurotropic arbovirus. It was first identified in 1937 from a febrile woman in Uganda, and it's very difficult to find this actual publication. So I'm not sure that she was any more than febrile, that she actually had neurologic disease. But that's when it was identified. We know it's a single-stranded positive sense RNA virus, like all the flaviviruses. It has a single open reading frame of 1,100 kilobases that make both structural and non-structural proteins that are translated as a single polyprotein. And when those are all put together, you get this icosahedral nucleocapsid right there, covered by a lipid bilayer, right there and like that. And then here is that the gene making both structural and non-structural proteins, just like when we talk about hepatitis C. This virus belongs to the Japanese encephalitis virus antigenic complex that includes Japanese encephalitis virus and also St. Louis encephalitis virus, but it is related to dengue, Zika, and yellow fever viruses. Oops. So what do we know about this? Well, there are at least 9 lineages, but really lineage 1A and 2 are associated with human diseases. And it's thought genomically that this emerged somewhere in Africa in the 16th or 17th century. It was introduced in North America, and some of us remember this, as a single lineage, presumably from an infected bird or mosquito from the Middle East in 1998. The life cycle involves arthropod vectors, principally mosquitoes. There are also avian reservoirs, and there are incidental hosts, which include human and horses, but most of the reservoir is in birds. And the primary carriers are the Culex mosquitoes, which we'll go over. So what does this do? So this virus persists in a reservoir between birds and mosquitoes, and that's where we have to talk about passerine or perching birds. So what are those? Well, this is a painted bunting. These are birds that have 3 toes forward, one toe back. That's a lot of different birds. Most of the passerines are amplifying hosts. They do not get ill, but in fact, there has been high avian mortality in certain species. And this is particularly corvids, which are ravens, crows, and jays, and exotic birds. Incidental transmission to end hosts is mammals and reptiles. So that's us, horses, but crocodiles actually can amplify. Human-to-human transmission can occur via blood transfusion and organ donation if it occurs at a particular time when patients are viremic and ill. So what's the mosquito? The mosquito is the Culex. These are worldwide, and we call them a common house mosquito, which we want to keep in our heads. So the life cycle is only 7 to 10 days. And this is a good time to think of all this during monsoon season in Arizona. So 7 to 10 days, the females lay their eggs in rafts in stagnant water. So they need a fair amount of stagnant water with a fair amount of organic waste. So this is usually rain barrels, swimming pools, anywhere. It could even be canals but they need to be stagnant. So there the eggs hatch into larvae. The larvae breathe and feed, but then change into non-feeding pupae, and then the adult comes out. And when the adult comes out, it flies away, but no further than 500 meters. So when I have monsoons, I'm always looking around my house and at my neighbors. Fortunately, they live, for many reasons, it's fortunate, they live pretty far away from me out in the Tucson Mountains. But to get these, you really need to be within 500 meters of their breeding grounds. Development does increase with increasing temperatures, so we're noticing that now. There are 3 major species found in Arizona: Culex tarsalis, which is the major one, Culex quinquefasciitis, and Culex pipiens. And this is the mosquito. It's a little larger than some. It tends to be brown, and there's no banding on the legs. So if you're looking for these, and then these are what we call crepuscular. They really like to feed around dusk and dawn. They may feed all through the night, but they like low light. So that's why they're crepuscular mostly. They are ornithophilic. That means they prefer birds, but they will feed on mammals and reptiles. They need blood to lay eggs, and since it's named common house mosquito, they can enter homes. And again, it would be unusual for them to lay eggs in your home unless you left your bathtub full of water and organic material, but they can get in. So what do they transmit? Well, what we're going to talk about: West Nile virus, St. Louis encephalitis virus, Japanese encephalitis virus, Western and equine encephalitis viruses, Rift Valley fever, and which obviously is in East Africa. But they also transmit Dirofilaria immitis, which is the cause of dog heartworm. And then they can transmit avian malaria, which is not of concern to us. So what is the life cycle of West Nile virus in the Culex mosquito? So the female Culex, which are what feed for blood meals, get infected when they feed on a vertebrate host, a bird, or even us or a horse, but mostly from the birds. The virus reaches the midgut, and that's where it replicates in the mosquito, and then it spreads to the salivary glands. Mosquitoes themselves do not appear to get ill from being infected. So in the salivary glands, they will then, the next time that mosquito feeds, it will transmit virus from the salivary glands to that host. So that's how the life cycle between vertebrate host and mosquito occurs. So what's the pathogenesis? Well, virus-infected mosquito saliva is injected intradermally with the mosquito bite. So the virus then can infect via cell receptor-mediated endocytosis, which is right here, and then goes and you get cell virus fusion. It can infect keratinocytes, which is the most superficial layer, or if it goes and then from the keratinocytes, it can be picked up by dendritic cells and brought deeper into the lymphoid system. And then it goes into draining lymph nodes, and you get an initial viremia. the virus then spreads throughout the reticular endothelial system, which gets a secondary viremia and organ spread, which usually occurs in 1 to 2 days. And this can persist up to a week, followed by the development of IgM antibodies, which sort of ends the process. Now, it's hard to find actual data, but most expert publications say that primary infection is presumed to confer lifelong immunity and is associated with circulating neutralizing antibodies, which in this case would be IgG. But it's actually hard to find that. There are no studies which actually show that. Now, the problem with this is in about 1% of cases, you get neuroinvasion, like the case we presented. And the mechanisms for this are unclear, but are presumed to be, one, direct viral infection of endothelial cells at the blood-brain barrier, passive migration of virus through increased permeability of the blood-brain barrier, so going in between the cells, and direct invasion by infected macrophages into the nervous system. You can also get neuroinvasion through the olfactory bulb. But once you get that, you get retrograde axonal transport, and you can get migration to the spinal cord of the brain, and that will cause then clinical illness. So, what do we know about West Nile in the United States? Well, as I mentioned, it was not really apparent in the United States until 1998. And that's when a cluster in New York City of cases of meningoencephalitis was seen, occurring in the summer of 1999. And that became a New England Journal publication. There were 59 hospitalized cases. Average age was 71 years. There were 7 deaths. And the attack rate was estimated to be 6.5 per million population. And that outbreak was coincident with extensive mortality in crows and exotic birds. So this was seen in the northeastern corridor where crows were dying extensively, coincident with this human outbreak. Because this occurred, Center for Disease Control and Prevention developed ArboNet. This is a passive reporting site for state health departments and CDC to collect these cases. And it tracks infections in humans, blood donors, animals, including mosquitoes, dead birds, and sentinel animals, and veterinary cases. And that's very important. And I was just on the Arizona State epidemiology meeting this morning, and Guillermo Adame was reporting latest numbers. So our state does collect these data and report them through ArboNet. So far in 2025, and this is undoubtedly a little behind, this was about a month or so ago, there were 24 cases in 14 states and 10 were neuroinvasive. So what does this look like? Well, this is the first couple of years. So ArboNet wasn't quite up until 2022. And once we get that, what we see is sort of this undulating pattern where some years, like 2003, are quite high. Other years, like 2011, are not very high. And this is undoubtedly related to mosquito proliferation, which is related to wetness. Where does most West Nile occur? So this is a complicated map. That's why I used this one, which just does it by state. So if we look at both of these, we see actually the upper Midwest seems to be the area of most endemicity. And this is this county map. We sort of see that. We also see Arizona. So we can see here Maricopa, Gila counties. We also see the Central Valley of California. So these are the areas most seen for West Nile. So what's the epidemiology in Arizona and what happened in 2021? So 2021 was this crazy year where 1,487, almost 1,500 cases of West Nile were reported. And 63% were neuroinvasive. Remember, that's a bias because many of these cases are minimally symptomatic and not reported. Again, like the original outbreak, 66 years was the median, so mostly in older individuals. and there were 1,000 hospitalizations. 7% of all these infections noted died. That was among an older population. Interestingly, 5% were among blood donors. And 99 cases were in Pima, 115 were in Pinal. Most of the cases were in Maricopa County, which we'll come back to. Now, why did this occur? Well, many of us remember 2021 was an extremely wet monsoon. It certainly was in Tucson, and it was in Phoenix. And although when you really look at the data, it didn't look that bad over the whole summer, there was a 23-day period where there was over 6.5 inches of rain. So I was looking at our recent monsoon here in Tucson, and so I would be lucky to gather 0.1 inch from a single storm. So while we have these huge downpours, this was a very unusual year for rain. And associated with that were increases in levels of Culex infected mosquitoes infected with West Nile. So we can see here, these are the infected mosquitoes, and then there was an attempt to modulate that with spraying and draining. Cases followed that, and then finally out in November burned out because A, the weather had dried out, and B, there was mosquito control.
What would you wager the number of cases are that aren't getting reported? If you had to guess at the real number.
Oh, well, the real number is probably 10 to 100-fold, because many cases are asymptomatic or minimally symptomatic. Yeah. So yeah, this is 1487 are the bad cases. So there were probably 14,000. So how are we doing now? Well, you can see that was really an anomalous year. So we've not had any cases like that. Last year we had 31 cases, and again, Maricopa County is a big county. Most of those cases were in Maricopa. Remember, compared to the other counties, Maricopa really waters a lot more than all the other counties. The other counties are much more desertified. So we see far fewer, and I do think that irrigation in Maricopa does account for some of this. As of the 22nd of July, there were 17 West Nile infections reported.
Yeah, Maricopa has flood irrigation.
Correct.
Yeah.
They have a lot of surface water, and they water a lot. And as we all know, certain neighborhoods you're forced to water, which we wouldn't see not only in Pima but in the other counties to that degree. However, so on July 22nd, this is from the Star, but actually from the Republic, Maricopa County had a death, and that's the 17 cases. But as of today, and Melanie bolded that for us, actually we reported 36 cases, of which 34 were in Maricopa, 1 each in Pima and Pinal. I'm going to just go back. These are the counties most impacted. Obviously Maricopa, Pinal, Pima, a little bit Cochise and Gila. So these, but particularly the south central counties are the ones most likely where we're going to see West Nile. Now again, some of these other counties have much lower population. So how else can you get this? Well, it turns out you can get West Nile through blood transfusion and organ transplant. So let's talk about blood transfusion. So during 2002, West Nile virus was found to be associated with a variety of blood components, including packed red cells, fresh frozen plasma, platelets. So this was reported in New England Journal of Medicine. So 23 patients got West Nile virus from transfusion. So starting in 2003, all blood components were screened through RNA and nucleic acid amplification testing. Despite that, there was one case in 2013 in a fatal immunocompromised patient. after a platelet transfusion with NAT negative component. So this should be very, very rare at this point, but still possible. Organ transplantation is a little different. So again, similar to blood transfusion, there were 4 organ recipients from one donor noted in 2002. This was again reported in New England Journal of Medicine. But screening has not been uniform. And since that report, there have been 10 reported cases. 8 of those were non-screened. So at least one publication says, consider screening organ donors, at least during months when West Nile is active. And that's obviously going to be during the summer months, during mosquito season, because this is not a standard practice during organ transplantation. And if we go back and look at our numbers, so now we have 36, which would be kind of like that. You know, is that reasonable or not? And that would be for every organ donation center to consider whether that should be added. So how do people present? So symptoms occur presumably in 20 to 40%. So I overestimated a little bit, Larry, because I didn't remember my own slide. And usually you get sick 2 to 14 days after infection. And the main disease one gets is West Nile fever. And this is like all these flaviviruses. You get this abrupt onset of fever, headache, fatigue, myalgias, and anorexia. And you may get a macular papular rash. And this would be important now because this could be confused with measles. And as you know, everyone is very concerned about measles now. And this persists anywhere from 3 to 10 days and is really a benign illness. But then neuroinvasive disease, again, like the patient I presented, occurs in about 1%. It's much more common in immunocompromised hosts, and particularly those who have B-cell deficiencies. So that's a solid organ transplants who are on corticosteroids and cyclosporin, tacrolimus, and patients who have received B-cell depleting agents like rituximab, and presumably anyone on high-dose corticosteroids. Chorioretinitis has been reported, but is a relatively uncommon manifestation. So this is a paper from Mayo Clinic by Kasuli et al., and they were really looking at doing PCR rather than serology. But I thought it was worth looking at what their experience at Mayo Clinic was in 2021, just to show you how bad that outbreak was. So they had 190 patients tested at a Mayo Clinic. The median age, again, this is a disease of older age. Among those, 75% who were tested required hospitalization, which is a very high number. And 14%, 20 of them, were admitted to the intensive care unit. So this really had an impact. 67% of the cases were neuroinvasive, and a quarter or so were among immunocompromised. 5% had severe neurological sequelae, and 5% died. The mean duration of symptoms before admission was 5 days, and I should say median, and the median duration of hospitalization was 6 days, which I will tell you is quite long for Mayo Clinic. So again, people would get West Nile fever, and then it would just progress on to neurologic disease. So really quite an impact when it is in epidemic proportions. So I have to mention St. Louis encephalitis virus because this is kind of a sister virus to West Nile. And in 2015, because the counties in Arizona were screening, they started picking this up. So among 62 West Nile virus cases, there were also 20 St. Louis encephalitis virus. So these can come along. And David Engelthaler, who was at TGen North, he's now with Arizona State University Health Futures. But his group genetically analyzed and found that St. Louis virus encephalitis virus had been introduced several times into the Southwest United States between 2011 and 2014. There are multiple clades and multiple introductions, and you can kind of see here, they were focusing really on the Southwest. So you can see the Coachella Valley and also Maricopa County. So we still see this, and we still had sort of that same ratio when Guillermo presented this morning, the 36 cases. There were several cases of St. Louis encephalitis. Or I should say, there were several instances of mosquitoes infected with St. Louis. I don't think there have been any cases yet. So misspoke on that. So this recent paper in Annals of Neurology is sort of had an impact. This is where they reviewed 47 studies of neuroinvasive disease. So presenting symptoms in addition to West Nile fever, which is the fever and the headache, musculoskeletal, they had altered mental status, focal muscle weakness, tremors, nuchal rigidity. Some patients could have acute flaccid paralysis. Some patients looked like they had Parkinson's disease and occasional seizures. And again, like the Mayo Clinic data, this was usually 3 to 9 days after symptom onset, and patients could have very long hospitalizations. Again, overall mortality was 9%. And when you survive this, you had neurocognitive improvement, memory, concentration defects, and depression. And I've seen this not just in the patient that I saw at Mayo, but we had patients with this at the Tucson VA. And it's fairly devastating because you come with this and you have very, very long cognitive deficits and balance issues once you develop this. So what's the laboratory profile? When should you suspect this? Well, the first thing is peripheral blood studies are going to be normal. So those aren't going to be helpful. But lumbar puncture can be very, very helpful. And that's what you have to do when you suspect this. So in West Nile, you get this typical, what at least infectious disease doctors call a viral pattern. Few red cells, usually 50 to 100 white cells, almost certainly under 500 that are usually lymphocytic. The glucose is not depressed. The protein is usually normal. And unlike in Ohio, if you go ahead and get this IgM in the CSF, it should be positive. So that's what happened in the case I presented, except they didn't do this. Neuroimaging can be abnormal in about 50%, but it's very nonspecific. So I'm not sure that's really helpful. And if you think of it, serum anti-West Nile virus, so-called MAC ELISA, is the best way to make the diagnosis. This usually occurs 3 to 8 days after symptoms and persists for 30 to 90 days. So 3 to 8 days is about the time someone who's been symptomatic with West Nile virus usually presents with West Nile neuroinvasive disease. So serology is going to be very helpful in these cases. So just to reiterate the diagnosis, it's always helpful to get serum EIA, IgM. This is called MAC ELISA because it's a IgM antibody capture enzyme linked immunosorbent assay, and it's useful after 5 days after symptom onset. Obviously, in immunocompromised hosts, it's going to be less accurate because they may tend not to have a robust antibody response. There is some cross-reactivity with St. Louis encephalitis virus. And if you're going to do the LP and you're thinking about this, you should order this test on the CSF. There is a plaque reduction neutralization test called PRNT. That's useful if you're concerned about differentiating St. Louis encephalitis virus from West Nile virus. And you can get a whole blood reverse transcribed polymerase chain reaction. That's what the Kasuli paper is about. And it looked like it might have been useful, particularly in immunocompromised hosts. They only got it ordered in about a third. but when it was ordered, it was positive in 80%, including 7 cases where the IgM was negative. So that can be of use. And in other papers, you can get this on the urine, and that may be even more sensitive. So that's something to think about if you really think somebody has this.
What would you say odds of crossover are with St. Louis?
I'm not sure I saw the exact percent on that, Larry, because St. Louis is pretty uncommon. So I can't,
Gotcha.
I'd be reluctant to tell you
No.
because I would be wrong. But it can, because they're very related viruses, and we'll come back to, do we really need to differentiate these two viruses? And this is what we're going to talk about. We can discuss is there are no specific therapies for either one. There is drug development. As I showed you, there are these structural and non-structural proteins. And if you've ever been involved with hepatitis C, that's exactly what was attacked to give us those oral direct acting viral drugs for hepatitis C. So presumably there could be drugs. Agents of possible benefit, corticosteroids. There are 2 reports that are pretty shockingly positive, but they're case reports. So in these cases, patients with neuroinvasive disease, so they were late, they already developed neuroinvasive disease, they got pretty high doses of solumedrol, 1,000 milligrams daily for 5 days, and those patients had pretty dramatic improvement. So that would certainly be something to think about. There was a large study of IVIG, and that one did not look to be helpful. And Larry, you had mentioned ribavirin and interferon. Do you want to comment?
So the CDC, if you go looking on their website, they've got a page for providers. And among corticosteroids and IVIG, they throw those 2 on as well. And quite honestly, most sources will say probably not worth your time. A lot of the issues too with these studies is you get a lot of crossover. So in some of these cases where they used IVIG, they had tried interferon. Did really this contribute anything? And mentioning Hep C for the folks that remember interferon and ribavirin treatment, you could be healthy as a horse, and that was a miserable 6 months or so of your life to be on that. So are you really making things better? You could just be making the patient profoundly worse in some cases, honestly. The only other thing I had really seen with corticosteroids is then a paper followed that was a retrospective review, and it was about I think they used about like 13.6 milligrams of Dex, like 90 milligrams of prednisone. And in that study, nothing seemed to get better except the length of stay, which was longer. So if you did steroids, you stayed for about 18 days as opposed to 10 days. So I would still agree, if you were going to look at a treatment, I would say corticosteroids, if anything, is probably your best bet. IVIG, even the CDC is, I think, hesitant to really endorse it. Theoretically, maybe there's some benefit in folks, as mentioned, if you've got these B-cell depleting agents on board, maybe some kind of humoral immunity problem, it might add something. But even for this interferon ribavirin, there's some in vitro data that they could work. It's really never been shown that they do. And for folks asking or thinking about it, there have been cases where people were getting treated for Hep C. They were already on interferon and ribavirin, and that did not seem to do anything for their West Nile. So I personally would avoid those. I think there's something to the steroids, but all of this is mired in, well, at least IVIG and a lot of crossover. Steroids, to me, I think there's something there, but it's very conflicting.
Okay. Now, there are vaccines for West Nile, and they're in horses. And so there are 4 horse vaccines currently licensed by U.S. Department of Agriculture. 2 are whole inactivated virus with adjuvant. Then there's a non-replicating recombinant canary pox. And then there's this is called a chimera vaccine, an inactivated flavivirus, where West Nile antigens are expressed in this yellow fever virus vector. So those are available for equine cases. There's nothing in humans, but there are some phase 2 trials. One is this Chimerivox Chimerivox WNO2. So this is an insertion of premembrane and envelope proteins of West Nile into this yellow fever 17D clone. So remember, this is an quote, a virulent virus, but if your patient is immunocompromised, there are some issues here. So it's live attenuated, so you really can't use it there. But so far, those data look good. And you have to really ask the question, or maybe we don't with what's going on. But we really should have these vaccines because the evidence obviously in horses that it works. And this early data in humans is that it works. And obviously developing antibody-mediated immunity seems to be protective. So it would be presumed that this would be something that could prevent the disease or prevent at least symptomatic illness. So what should we do about this? So vector management and control. And so again, I have this appointment with the state now, and it brings me into this whole new world. So there's a lot of things the counties in Arizona all do to try to control this. And they spend a lot of time on this. And so the first is vector monitoring. So all the counties do this. Obviously, Maricopa is our biggest county, so they have environmental services. So they're out setting out mosquito traps, and they will count, speciate, and test. And so, for example, they are testing for both Culex and Aedes, and I'm going to talk about Aedes. And if they find a Culex, they will look for West Nile and SLEV. And so that's what Guillermo was talking about. So we've got about 2/3 of Culex mosquitoes that are infected are West Nile, and the others are St. Louis. So both are circulating in the mosquitoes. The Aedes, if they trap an Aedes, they're going to look for Zika, chikungunya, and dengue. They will then, if they find an area, they will abate. And what's that? That's larviciding and adulticiding. So that's spraying. They will provide, and if you live in Maricopa County, the Gambusia fish, which will eat the larvae if you have some large area. And then everything gets reported to Arizona Department of Health Service, and that is Guillermo Adame. He's excellent. And so they're monitoring this all the time. So what can you do for personal control? So Melanie sent me an advertisement from ACE, and it wasn't that, but they were correct. So what should you do? Well, for these mosquitoes, these are crepuscular. So dawn and dusk are particular times. If you're concerned, don't go outside. If you do go outside, wear long sleeve shirts and pants and use insect repellent. The best repellent is DEET, followed by picaridin. And all the other things, I think that the general consensus is those don't work. So DEET is the best. I know people think because it's harmful. There's no data that DEET's harmful. DEET is really the best repellent to use. I didn't talk here about using permethrin. Permethrin actually kills mosquitoes, and so you can put that on clothing. You never put it on skin, but in fact, my hat has permethrin. I have hiking clothes that have permethrin. This is very common, and you can spray stuff with permethrin, which in my backpacking days I did. So those are the things you can do. Long sleeves, you can add permethrin to those clothing, use DEET, and stay outside in particular if you're concerned about these. Obviously, reducing mosquito transmission is you want to get rid of the breeding grounds. So look around for standing water. And for Culex, this is really big stagnant water. So gutters are really important. Other pools, I have a cistern that is screened off, but I better get up there. So I should make sure, because my cistern has like 1,200 gallons. So yeah, well, they would kind of not do well because it's a cistern, but still any standing large water, and particularly that gets stagnant so it has organic material. And again, these are house mosquitoes, so use screens and keep your doors closed so they don't get inside. Now, everyone gets really excited about, sterilizing males like they've done in Aedes, or infecting with Wolbachia. And I actually learned this on a PBS show. So we should all support PBS. That's where I first learned it, is it turns out that Wolbachia may be worse for West Nile. So while infecting Aedes mosquitoes with the bacterium Wolbachia really reduces a transmission, it probably doesn't work, and it may make it worse for transmission of West Nile and Culex. I'm not sure I understand that, but Culex has gotten a lot less attention than Aedes, and there's, but Aedes transmits a lot nastier viruses. And that's what I wanted to go over just to finish up with Zika, chikungunya, and dengue. So these are all transmitted by Aedes. The three species, Aedes aegypti, which is the yellow fever mosquito, originally came from Africa, brought here in slave ships and then colonized North and South America. This one lives near humans in small water containers. Aedes albopictus is the Asian tiger mosquito. It's adapted to cooler climates. And then Aedes sollicitans, really not a problem, but here's what they look like. And this is what I was talking about. The Aedes have banded legs. So, and they're much smaller than Culex. And here are the ranges from CDC. So you can see we do have Aedes in Arizona, mostly though in southeast United States, but we don't have albopictus. So we, at least not yet. And here's a nice table that actually Perplexity made for me. And I thought it was really good. So to compare the two mosquitoes, so biting, Aedes is daytime, early morning and late afternoon. Culex we talked about, crepuscular, dawn to dusk, but really at dawn, at dusk. How do they look? These are small, black, and then they have the silver stripes on their legs. These are brown, medium sized, without those markings. Breeding sites, really important. Aedes, and I'm going to come back to this in a second. Tiny, Coke bottle caps. They can do anything. And the classics are flower pots and inside of tires, where really Culex needs larger bodies of stagnant water. Egg laying is just above, singly above the waterline. That's why they don't need much, and they're very resistant to drying. Where again, the Culex is in rafts, and they do dry out. And again, main diseases, dengue, Zika, chikungunya, yellow fever, and West Nile, St. Louis, Western and Eastern, and of course, Japanese I didn't put there, and dog heartworm. Feeding preference, the Aedes really likes humans. Culex will feed on mammals, but really prefers birds. So let's talk about Zika, chikungunya, and dengue. As I mentioned, we do have Aedes aegypti, but for Arizona, Zika, chikungunya, and dengue, we don't have any locally transmitted cases. The last local case of chikungunya was 2019. Dengue, only travel-related cases, but it is endemic in Puerto Rico and U.S. Virgin Islands. But remember, and I just heard this morning, dengue is endemic to Mexico. And there are a lot of cases reported, fewer in Sonora than as you go south, but it's there. And we had 14 imported cases in Arizona this year. Chikungunya right now, there is a major outbreak in Guangdong in southeast China. And they are doing all sorts of things. They are spraying and have education about getting rid of standing water to get rid of it there. So it's a huge problem right now in China. And I would be remiss, and Steve would get after me if I didn't mention Oropouche virus, because this is a new virus. It's an orthobunion virus that is found principally in the Amazon basin. So a lot of outbreaks in Brazil, but also in other areas of South America and in Cuba and the Dominican Republic. This is mostly transmitted by biting midges, so maybe you'll hear about this the next time. But there have been some transmission from mosquitoes. The reservoir is likely non-human primates, sloths, and possibly birds. Really no human-to-human transmission. And like all these viruses, you know, you get abrupt fever, severe headache, chills, myalgias, arthralgias. But there is this, like these other viruses, 5% get aseptic meningitis, encephalitis, and but you can have bleeding. So we'll see if Oropouche gets to us, but I know the state is already aware of it, and the CDC. So we're ready now for questions and comments.
Doesn't look like we have any questions right at the moment. Dr. Klotz, you have a comment?
Yes, I do. That was an excellent presentation, Neil, and a lot of good information about the different mosquitoes involved. I thought I liked that part a lot. Because, you know, when you're out having your evening drink or whatever in Tucson and it's still light out, that's when Aedes are around. And as Justin Schmidt used to say, they just love to bite your ankles. That's where they go for. And that's very typical. Got your shorts on and suddenly you've got Aedes biting your sides or the ankles.
Yeah, that's one place that I get bit is on my ankles. I'll have the long sleeves, I'll have the pants, but they're going after my ankles.
Gotta deed up. Well, I was just hiking, I was in Southern Oregon and we ran into this Nature Conservancy virus group. And one guy actually, which you know, had his pants tied down.
Okay.
And that's more for ticks, but that's the same idea. You know, if you're gonna do it, you gotta really cover up.
So with dogs with heartworm, there's the heartworm,
Correct.
but there isn't something like that necessarily for humans. You're saying there's no.
No, humans get they're an incidental host for Dirofilaria immitis. We covered that before. Remember, I showed an ophthalmologist removing a Dirofilaria
that's
worm.
right.
That was the first one.
Oh, yes, I remember that video now.
They typically are too large to get through the alveoli and the capillaries and be coughed up. So they get stuck, and then they're just they're a granuloma is what it is, or a lesion that people think, oh gee, on the X-ray, on the CT, this looks like it could be a cancer. Do you smoke? Oh yeah. They all end up getting biopsy.
Yeah, that was a traumatic video. I was not prepared when you sent me that to test it. I'm like, oh. Anyways, yeah, so hosts can be, you said horses as well, and there's
For West Nile.
for West Nile.
Yeah,
Okay, and there's vaccines for horses.
correct.
There's no vaccines for humans,
Correct.
not yet though.
Oh,
Any other animals that they're working on?
Well, no, because horses, I don't think crocodiles have reached anyone's interest. So it's humans and obviously horses were very much impaired. You know, when this was going through in 1999.
Okay. So does the virus actually, as long as you don't get the neuro part, does the virus will just run its course?
Correct. And so most people, and that's the issue, most people are going to become immune to this. And the presumption is that's lifelong. But I haven't seen, I'd like to see some better data on that. It's just sort of a presumption. And I think, I want to say Lance Peterson, right? He's, you know, he has stated that, but I don't know how firm that those data are, that you couldn't maybe, that immunity might wane over time. And that would be a big thing because this tends to occur in waves. And so, so if it, you know, if people had gotten bitten and become immune, then those subsequent waves wouldn't be a problem.
So what would that trial look like? Somebody that has been known to have West viral, then to try and infect them again and see what happens?
Well, you wouldn't, yeah, that would be, that, you clearly haven't been in front of the IRB lately, no. Because, no, it would just be doing epidemiologic data.
Okay,
One way, yeah, you could probably look at how many people, and I don't know that that's been done, Steve, you just look at IgG, that would be the marker. If you have IgG to West Nile, it would be presumed that you would then be immune.
and it seems like the older population tends to have much more of an issue with.
Yeah, this is a classic. It's sort of like valley fever, where the impact is clearly, and as you get older, and again, the reasons for that, I don't know, are clear. There may be some immune senescence. But yeah, almost all that disease, that's why I showed that over and over, is 60 and above where you see neuroinvasive disease. So presumably people younger than children are getting infected, but not having a problem.
Not having a problem. Did you think about all the sports that are down
Correct.
at dusk?
The crepuscular sports,
In the
particular,
parks that have sprinkler systems and might have pools of water, right?
correct. That's exactly right.
Interesting. All right. Well, it doesn't look like we have any questions today. Our audience is quiet compared to last week.
Oh,
Neil?
hand was raised.
Neil,
Yeah.
would you want to address the issue of how the epidemic moved across from the east to the west coast?
Yeah, I didn't get into that, Steve, but you're exactly right. It did. It was introduced presumably into the New York area, and that's exactly right. And it moved through passerine birds. So it just, once it got introduced, it did. And the only story I have, because I didn't really go over that, I knew that happened, because I was out camping actually on the Green River where the Yampa comes in, and I knew that this was in about 99 or 2000, and we were getting bitten to death. And I was just shocked I never got West Nile, but we were very aware of that movement. And that movement occurred through persistent infection of passerine birds.
Well,
Do you have more comment on that? We have Tanya, we have to get
Yeah.
to.
The other connection was that the water birds, which are migratory, they move in the southern states of the United States up to the Arctic to breed. And most of our water birds, and they get infected, they don't die, but they all mix together up in the Arctic. So it slowly moved by movement back and forth during the different flyways, the eastern flyway, the Midwestern, etc. And this
I
is
didn't know that. No.
yeah.
Oh. All right, and Tanya, you have your hand raised. Did you have a question?
Okay, so just curious about other animal vectors. So, if we're looking at these specific birds as being the vectors for the West Nile virus, are we worried about other domestic animals? So, like where I live, there's a lot of country area, and a lot of people have dogs, and they have chickens, and they have turkey, and other birds and things. So, are we worried about those being vectors?
That's a great question. I might have to defer to Steve. I haven't seen much data on domestic animals and dogs. Obviously, I think chickens, they're certainly susceptible. But I haven't seen much data on that, those being major amplifying reservoirs more than wild birds. Steve, do you have any thoughts?
Not other than the fact that horses and humans are considered dead ends because it's not likely that a naive Culex tarsalis or Quinca fasciatus will feed on that infected human and then pass it on to another human. So that's why they're considered dead end hosts. And in Pima County, almost every horse has been vaccinated for St. Louis encephalitis or equine encephalitis, excuse me. Another problem, but other than that, I don't know, Neil.
Yeah, so they could be reservoirs, but so are wild passerines, which are a huge population. Almost every bird you see is a passerine. So I would think that they are much more of a problem because the mosquitoes are feeding on them everywhere. And then we're an incidental host. So maybe you want to be more concerned about your Gila woodpecker than the chicken your neighbor has, but I don't know.
All right. Well, that's gonna wrap us up for today. Thank you, everybody, for joining us, and join us again.
I did.
Oh, we do have something. There's no dumb question. What do we have?
You know, I don't know what the genesis, it's just that crocodiles are mentioned. Yeah, I have no idea. I actually was recently in the Serengeti and we got to see the hippos and the crocodile. And let me tell you, you don't get out of your vehicle there because those were Nile. So I don't know how crocodiles were associated with West Nile and how somebody thought that they might be a replicating host.
Yeah, so the question was how did people come across to realize that crocodiles were involved? Yeah, so yeah, that's very interesting.
I don't know.
Oh, we got another question here. Okay, here we go. Is spraying alone being proven a good to get rid of mosquitoes? Since you left Arizona, I noticed that they do down in Mississippi. I see it being very strange to you.
Yeah, no, spraying of sites, as we said, larvicides and adulticides can be very effective. The story, so people were very upset. So during the Arizona Infectious Disease Society meeting, Ken Komatsu of the state talks to us, and this is when there was a huge impact because there was a lot of neuroinvasive disease. So a lot of the clinicians were kind of upset about control. And it turned out control is not under the health department. It's actually under this different entity. And this was a huge problem. Again, 2021, this is toward the end of COVID. And so if a government entity came out and said, we need to spray, your swimming pool, people were not very receptive to that. So it was a difficult issue, but spraying does work. Obviously, reducing habitat. And so for culex, reducing stagnant water pools is critical. And again, in 2021, there were a lot of, that was a big problem in Arizona. There were a lot of swimming pools that were not being used. And those are major culex disaster sites. But it is difficult because it's government has to come in, and a lot of those sites are private sites like your house. So think how you might react if someone came with spraying material to your house. And would you invite them right in, or would you do something different?
All right.
So in Mississippi, it might be different because there's a lot more water. And so that may be a lot more environmental spraying. But in Arizona, a lot of it is domestic spraying.
All right, I think that's going to end our questions. All right, again, please join us in September. I will be sending out my thank you email to everybody with the links for the evaluation and links for the next session that you can register for. Along with all of our EMS folks, of course, go ahead and respond to my email and I will get your certificates to you. And the code is in the evaluation for the CME credits. Our EMS folks, you can of course have your account set up and get your transcript of all of the sessions you've been attending to us. And if you have any problems with that, reach out to me and we can get that taken care of. All right, so yeah, I've been born and raised in Arizona, never thought you'd leave the state. Well, it looks like you did. I think you're the one that went to Mississippi.
I told him.
Right? We do like it here. It is hot. You're not missing the heat. Let me tell you that right now. All right, folks, again, thank you for joining us, and we look forward to seeing you next month. Take care, everyone.